Assalamu alaikum. I would like to thank the organizing committee for the invitation and for preparing this conference. And thank you very much for the nice introduction. I'm going to talk about cutaneous lymphoma, primarily T-cell lymphoma, which represents the largest group of lymphomas involving the skin. We'll start with, let's see. Okay. We'll start with 3 cases, then we will go over them again during the presentation. The first case is a 27-year-old lady presented with chronic generalized scaly plaques on trunk and extremities, and skin biopsy was taken. So here, skin punch biopsy, as you can see, with superficial dermal lymphoid infiltrate, as you see here. On higher power view, these infiltrate in papillary dermis with infiltration of the epidermis as a group of cells here. Higher power view that represent that these lymphocytes are large in size with mild hyperchromasia, irregular nuclear contour, and there's some papillary dermal fibrosis here. Differential diagnosis, mycose fungoides, then other mimickers, Pityriasis lichenosus chronica, or peripheral T-cell lymphoma NOS, or lichen planus. So we'll go along these things in the presentation. Just to give you an overview. So this particular patient was treated for mycose fungoides, and 10 years later, she presented with an elevated nodular skin lesion on the left thigh, and skin biopsy was taken. As you can see here, there is a dense dermal lymphoid infiltrates in superficial and deep dermis. On higher power view, you see these lymphocytes are large with focal infiltration of the epidermis or epidermotropism, and the size of these lymphocytes are larger than the previous biopsy. So here is higher power view, hyperchromasia, mitosis, large size. And this is the immunophenotype of the infiltrate. So it's CD3 positive, 4 positive. See the contrast between 4 and 8. They are 8 negative with loss of CD7 expression, and they are CD30 negative. So differential diagnoses include here mycose fungoides with large cell transformation, which is the diagnosis, or anaplastic large cell lymphoma, which is CD30 positive lymphoproliferative disorder. Then others, gamma delta T cell lymphoma, NK T cell lymphoma, lymphomatoid papillosis. But here with the clinical history, so is helping us more toward the diagnosis of mycose fungoides with large cell transformation. So case number 2 is a 2-year-old boy presented with 3-month history of fever, skin rash on examination, erythematous woody indurated plaques over lower limbs and forehead and right wrist. He had hepatosplenomegaly, and this is a skin punch biopsy from the patient. As you see, there is inflammatory infiltrate lobular in the subcutaneous. This is higher power view, so the infiltrate is primarily in lobular pattern in subcutaneous fat. There is no significant involvement of epidermis or dermis, so it is restricted to subcutaneous. This is a higher power view, the atypical lymphoid infiltrate rimming the adipocytes. As you can see, this is a higher power view, again the same. This is another one with the rimming atypical large lymphocytes. So this is the immunophenotype. So they are primarily CD3 positive T cells that express CD8. And if we compare CD8 to CD4, CD4 is negative. This is a higher power view for the same immunostain. CD3, CD8 mirroring each other. We have high Ki67 proliferation index rimming the adipocytes, and there is negative staining for CD4. There is a mild decreased expression of CD7, CD20 is negative, 56 negative, and TDT is negative, and EBV and cytohybridization is negative. This is smear from the bone marrow. So as you see, this is hemophagocytosis. This is the histology from bone marrow highlighting the hemophagocytosis, and this is CD68 highlighting that. So patient was sick. So differential diagnosis, subcutaneous polyclast like T-cell lymphoma, primary cutaneous gamma delta T-cell lymphoma, extranodal NK T-cell lymphoma nasal type, aggressive epidermotropic CD8 positive CTCL. So we'll go along along these things in the presentation. So this group of diseases they involve the subcutaneous in prominent fashion. Case number 3. This is a 45-year-old lady presented with 1-year history of asymptomatic skin lesions that are hypopigmented, and the clinical differential diagnosis was psoriasis and mycosis fungoides. So as you see, the punch biopsy, inflammatory infiltrating superficial dermis, they are tagging dermo-epidermal junction in with prominent pattern of tagging, and there is papillary dermal fibrosis. They are going along the eccrine ducts. Here they are a little bit large in size, mild hypochromasia and papillary dermal fibrosis. And this is the immunoprofile. So they are CD3 positive, CD8 positive. They are similar to each other. CD4 is negative. This is CD3, CD8 higher power view, and CD4 is negative in the cells tagging dermo-epidermal junction, and they are positive in dendritic cells and in epidermis and macrophages in the dermis. So the T cells are negative, and here the cells, they are negative for CD7. So differential diagnosis, mycosis fungoides, CD8 positive, mycosis fungoides, inflammatory vitiligo, lymphomatoid drug eruption, aggressive epidermotropic, CD8 positive, CTCL. So these are all, they are CD8, they can present with CD8 positive epidermotropic atypical lymphocytic infiltrates. So we'll go through that in the presentation. So cutaneous T-cell lymphoma is a big group of disorders. The largest group include mycosis fungoides and Sézary syndrome, and this represents 65% of CTCL, followed by CD30 positive lymphoproliferative disorder, including LYP and ALCL, representing 25%. Then there are a rare group of diseases representing all of them 10% of the CTCL cases. Some of these forms are aggressive, such as aggressive epidermotropic CD8 positive CTCL, and some of them are indolent, like primary cutaneous acral CD8 positive T-cell lymphoproliferative disorder. So we'll go through these, some of them. So in evaluating biopsy from patients with possible or clinical impression of cutaneous T-cell lymphoma, along other diseases in pathology in general, we have to put the clinical and histopathology together, including morphology, immunostains, and possibly molecular to reach a definitive diagnosis. So in cases where CTCL is suspected, we look at the age. For example, mycosis fungoides is common in older patients. We look at the morphology. Is there patch, plaque, tumors, chronic illness that's seen in mycosis fungoides? Is the disease is aggressive with prominent ulceration? That is seen, for example, in aggressive epidermotropic CTCL. Is there hypopigmentation, papules in LYP, single lesion, multiple lesions? If there is history of a systemic lymphoma with secondary skin involvement, and the immunostatus for the patient, if the patient is immunosuppressed post-transplant, such as EBV positive lymphoproliferative disorder. So we look at all these parameters and we match them. We try to match them with the histology, immuno, and molecular. So in evaluating skin biopsy, we look at the structures available, the structures of the skin. So the skin, as you know, composed of epidermis, dermis, adnexal structures, subcutaneous. So we look at epidermis. If there is atypical infiltrate in the epidermis, that's epidermotropism. The dermis as well. So epidermotropism is seen in mycosis fungoides. We look at the follicles, like folliculotropic mycosis fungoides. We look at eccrine glands, syringotropic mycosis fungoides. So for example, folliculotropic mycosis fungoides is more aggressive than the conventional mycosis fungoides. So we look at the structures of the skin. Then we look at if there is green zone, if the infiltrate primarily in the dermis. Then we look at the distribution of the infiltrate. If it is wedge-shaped like this, which would be corresponding to papular lesion, classically seen in lymphomatoid papillosis. Then, as mentioned, we look at subcutaneous. Is there subcutaneous involvement? Is the subcutaneous involvement exclusively subcutaneous, or there is dermis and epidermal involvement? If it's exclusive, it's like panniculus like T-cell lymphoma, like our child. Gamma delta involve all. NKT cell lymphoma involve all. This is example of subcutaneous panniculus like T-cell lymphoma. Well, there is mainly subcutaneous involvement. We look at the vessels. If there is intravascular lymphoma, like B-cell lymphoma or NKT cell lymphoma, these are rare diseases, but you never know. If you look at them, if you don't look for them, you may miss them. And then we look at the infiltrate and the relationship of the infiltrate to the vessels, for example. Is there angiodestruction? Is there necrosis? And that's seen, for example, in NKT cell lymphoma, can be seen gamma delta T cell lymphoma, EBV, positive lymphoproliferative disorder do that. So we look at the vessels and how they are affected. We look at ulceration. So ulceration is uncommon, can happen with mycosis fungoides, but it's not uncommon. It's more common with cutaneous T-cell lymphoma, CD8 positive cytotoxic markers. They induce necrosis more than mycosis fungoides. So necrosis, ulceration is another thing. We look at the morphology of the inflammatory infiltrate, the size, are they monotonous, polymorphous population of cells. And then we keep in our mind benign mimickers, especially in mycosis fungoides, early stages of mycosis fungoides. So there is a long list of mimickers. These are just examples: pityriasis lichenoides, lichen sclerosis, lymphomatoid drug. There are many causes. Here's some of them. For example, pityriasis lichenoides chronica. They may have similar appearance to mycosis fungoides, but they have interface changes, dyskeratosis, RBC extravasation. They present with maculopapules with scales that fade with minor hypopigmentation or hyperpigmentation. And as mentioned, the lichenoid infiltrate, which is uncommon in mycosis fungoides. As mentioned before, here's another mimicker, pigmented perberic dermatosis. They can mimic mycosis fungoides histologically, but if we look at the distribution of the lesion, this entity usually in the lower legs, but mycosis fungoides exclusively involving the lower leg is uncommon. And these are associated with RBC extravasation, hemosiderin, which is uncommon in mycosis fungoides. So distribution of the lesion is helpful as in this entity. Then another one here, chronic actinic dermatitis. So this one of the entities that can be mistaken as mycosis fungoides, but the clinical is helpful because these, from the name, they are usually at sun-exposed areas, while mycosis fungoides is generally in sun-protected areas. So if we keep this in mind, that will help us in navigating through the differential diagnosis of atypical lymphoid infiltrate in the skin. So as mentioned, chronic actinic dermatitis, sun-exposed area, mycosis fungoides, sun-protected areas. This entity is usually CD8 positive. Mycosis fungoides is commonly CD4 positive, but it can be 8 also. So lichen sclerosis is another thing, especially the early stage, can present with lichenoid inflammatory infiltrate that can mimic mycosis fungoides, but in advanced lesion, there is hyalinization, edema in superficial dermis, which will make the diagnosis more easy. And for the location, usually they are exclusively in the genital area. but they can happen at other sites, but usually in the genital area, while mycosis fungoides exclusive in genital area is uncommon. So again, distribution of the lesion is helpful. Now, lymphomatoid drug eruption, and this can mimic mycosis fungoides. That there are medications that can cause inflammatory infiltrate in the skin that can look like MF, but they are not. They are UGCD8 positive. An example of that is anti-epileptic medication. And what makes things more difficult, for example, this medication, the mogamulizumab, used in treating mycosis fungoides. So it is known to cause drug rash overlapping with mycosis fungoides. So here are the patterns of side effect of this medication: spongitic dermatitis, lichenoid inflammatory infiltrate, granulomatous reaction pattern, and granulomatous reaction can happen with mycosis fungoides as well. But how can we navigate through this? We look at, again, at the clinical, again, histology and other parameters. So lymphomatoid drug for this disease, for this medication, there's predilection in the head and neck area. While mycosis fungoides is usually in other sites. It presents with morbilliform dermatitis presentation. It has photoaccentuated pattern, unlike mycosis fungoides. This is uncommon in mycosis fungoides, usually in sun-protected area, as mentioned. And they are usually CD8 positive, while mycosis fungoides is CD4 positive, usually. Here is an example of a case that we published. We published a lymphomatoid drug eruption. It's called keratodermal-like T-cell dyscrasia. This patient was presented to the dermatology clinic with a keratodermal-like picture. There's redness in the palms and soles with itchiness and scales, and biopsy was taken. And as you can see here, there's superficial dermal lymphoid infiltrate. The lymphocytes are a bit large, they are a bit hyperchromatic, irregular nuclear contour, they infiltrate the epidermis. But we, at that time, we felt that this is not enough for mycosis fungoides. It's just falls short. It doesn't show enough features to call mycosis fungoides with confidence. So we said this is likely T-cell, unevolving T-cell dyscrasia. Then the patient, then the clinician, she looked back into the medication, and she found that patient is taking statin, one of the statins, which is reported to cause keratodermal-like T-cell dyscrasia. So before that, before the biopsy, they were treating the patient with steroid. It's not responding to steroid. So after the biopsy and suspecting that the statin was the inducing drug, they gave steroid and stopped the medication. And this is 6 months after stopping medication, lesion resolved. So that's another thing. The other scenario, this can be called as mycosis fungoides, and patient will continue to keep taking medication and receiving treatment for mycosis fungoides. So there is a big difference. Here is the other entities that overlap with mycosis fungoides. Mycosis fungoides, this represents the pathogenesis of mycosis fungoides. They have the T lymphocytes. They have multiple receptors, and they infiltrate the epidermis through specific surface molecules, and then they infiltrate the epidermis. They tag the dermo-epidermal junction, and they go around the Langerhans cells. So that's why we see Poitier microabscesses, because these atypical lymphocytes, they go around Langerhans cells and they form these Poitier microabscesses. And the other thing, another soft criteria or morphologic key that I use when the mycosis fungoides is clonal, are clonal T cells. They are clone. So likely they are related to each other. So when they infiltrate the epidermis, they infiltrate it in a systemic way, organized way. They tag the dermo-epidermal junction. They go into the epidermis, forming protein microabscesses, while reactive conditions, they are different population of T cells. So they infiltrate the epidermis in haphazard way, like air blowing the T lymphocytes within the epidermis. So they don't have the organized pattern seen in mycosis fungoides. This is one of the features that is observed with the way that the atypical lymphoid infiltrates present in the epidermis for mycosis fungoides cases. So this is represent the evolution of the lesions. So at the beginning, there is the red are neoplastic and the blue are reactive T cells. So in the early stage, there are reactive cells. So as the lesion progress, there are more neoplastic cells. Then in the caesarea phase, the cells become less in the skin. They go into the circulation. If you do biopsy of caesarea patient, you may not see much. So as the lesion progresses, more neoplastic cells, it's more easy to appreciate the morphology, more easy to read the immunohistochemistry, and the yield for molecular will be higher because we have more cells. Here is the patch, plaque, tumor. Again, we talked about that, the follicular tropism. This is a variant of mycosis fungoides with multinucleated giant cells eating elastic fibers, causing redundant skin in a background of neoplastic T cells, granulomatous-like skin. Pagetoid reticulosis is a variant, single lesion, prominent epidermotropism, CD8 positive T cell infiltrate. Immunophenotype, commonly CD4 positive, can be CD8 positive, rarely double positive, rarely double negative. Then we use T cell gene rearrangement in difficult cases or early stages of mycosis fungoides. So we try to use T cell gene rearrangement in cases where we have difficulty in making diagnosis. So basically, the regions in the T cells, we have gamma delta gene rearrangement, which happened before the alpha beta. So we have alpha beta gene rearrangement and gamma delta. The gamma delta happened before, and it can revert, go back. So this can happen in reactive conditions, while alpha beta is seen in neoplastic conditions in T cell lymphomas. So this is more specific for malignancy, less sensitive. And this is more sensitive, but less specific for malignancy. So we look at the clone. It has to be single clone, good amplitude of the clone. If we have multiple clones like this is pseudoclonality. So PCR sensitivity in early stage of mycosis fungoides. So sensitivity 50% for patch, then increase the yield as the lesion progress. Specificity for gamma delta is poor, is not that specific. So this is another way of technique using the TCR. So we do two tests. If we have gamma delta, for example, PCR, we do 2 tests from 2 different sites, preferably 2 different times. So if we have same clone, 2 different sites, different times, exactly same clone, so this is neoplastic. This would suggest that this is neoplastic process. This is more of mycosis fungoides. While if there are different clones, the clone disappeared, this is more of reactive condition. NGS is said to be has higher sensitivity than PCR. And also higher specificity. It discriminates neoplastic or mycosis fungoides more than the reactive conditions in a better way than the PCR. But again, it is not fully specific. So we have again to put everything together. Other application of NGS, discrimination between disease recurrence and other inflammatory conditions like the drug rush that we talked about due to medication used for treatment, assist disease recurrence, follow-up for response. Again, here we have to put, just to emphasize that we have again put everything together. Then we have to weigh things, the cost effectiveness. Is it really cost effective to do these expensive molecular tests, or take additional biopsies, do immunostains, and follow up the patient? So we put things together according to our setup. So this is the case I talked about before. This is the mycosis fungoides, and this is large cell transformation. So differential diagnosis, ALCL, but this is CD30 negative. You can include LYP as CD30 lymphoproliferative disorder. This is the guy who described LYP. It was, I think, 1968. That this disease looks ugly, but it is under microscope looks ugly, but clinically it is more indolent. And this is one of his patients. With shape, large cells, typical. They are CD30 positive, and they present as a group of papules that come and go, leaving scars. Differential diagnosis: anaplastic large cell lymphoma, usually single lesion, large in size, more than 2 centimeters, according to some authorities. So that's the. So there are different types, long list of types of LYP. These are in the WHO. So we have A, B, C, they are 4 positive. Then D, E, LYP with DUSP, they are CD8 positive. And the differential diagnosis here, LYP type A, ALCL, MF. So they overlap. The significance that this group specifically, we'll talk about that. D and E overlap with aggressive T-cell lymphomas. Here the type A with shape, scattered atypical cells. This is very few large cells similar to MF, and this reminiscent to ALCL. There are more larger cells. D, it is CD8 positive. The others are CD4 positive. So this one is CD8 positive. It overlaps with this aggressive entity, but the clinical will be helpful. It presents as papules, epidermotropism, as you can see. So if you don't know what's the history, it's very difficult. This is type E. Look like NKT cell lymphoma nasal type. It looks very aggressive under microscope, but it is clinically papules, come and go, leaving scar. Here there's ulceration, black discoloration, because it involves the vessels, causing necrosis. This is type E. So clinically, they are the same, but it's good. It's important to know because they overlap with other things. LYP with DUSP22, this overlap with large cell transformation and mycosis fungoides. Then other types, folliculotropic, MF, LYP, syringotropic. Then I have seen a case of this LYP with CD1A dendritic cell hyperplasia, mimicking Langerhans histiocytosis. So clinically, it looks like LYP, but under microscope, you see a lot of dendritic cells. And initially, you may think that this is Langerhans histiocytosis, but again, the atypical lymphocytes, the presentation is different, and they have seen one case similar to this, pseudocarcinomatous change in LYP. So there is LYP. On top of that, there is pseudocarcinomatous hyperplasia. And that case, the initial biopsy was superficial shave biopsy. So you mainly see pseudoepithelial hyperplasia. You may think this is squamous carcinoma. Then a few atypical lymphocytes in the dermis. Then with the excision, you see the whole thing. This is then there are the gamma delta LYP, oral involvement, and this as persistent agglutination of LYP. I have seen one case like this. So the patient here, they present with patch or plaque of mycosis fungoides. Then on top of that, there are LYP that they come and go. They appear as papules. Then they ulcerate on top of plaque. So our patient, he presented with classic picture of mycosis fungoides. Then he presented to the dermatologist at a stage of healing LYP. So he presented with the patch of MF. Then in the center, there is punched ulcer. They thought this is pyoderma gangrenosum within the mycosis fungoides. But this is a rare variant of MF with LYP. So the patient later in follow-up appointment, he brought pictures with different stages of the lesion that ulcerate on top of the plaque lesion of mycosis fungoides. That was very, very interesting case. This is the one that we saw before, the epidermotropic. So for this one, this is MF, CD8 positive MF, hypopigmented. So for this one, we go along the differential diagnosis of CD8 positive epidermotropic infiltrate differential diagnosis. So this include LYP type D, pagetoid reticulosis, and MF CD8 positive. This group is indolent, generally. Even CD8 positive MF, it is indolent disease, which is compared to this one, which is very aggressive disease, but the clinical will be helpful. This is the aggressive epidermotropic. So it's bad, aggressive, fast clinical course, ulceration. They may involve subcutaneous, not common, and they are CD30 negative, 56 negative, EBV negative, TCR gamma negative, overlap with gamma delta, so it should be negative. And here is the differential diagnosis. These are lymphomas that involve subcutaneous. So we talked about that, pannucleus like T-cell lymphoma, exclusive subcutaneous, gamma delta, and NKT cell lymphoma. So for this one, again, they are 8 positive, beta F1 positive, and the gamma delta here.
5 minutes.
TCR gamma delta.
5 minutes.
Okay. TCR gamma delta here is positive, and the NKT cell lymphoma, EBV positive, 56 positive. So, and as you see, prognosis is bad. As you move, prognosis is bad. This is the gamma delta. We talked about that. There is angiocentricity, involve all the structures of the skin. They are gamma delta positive. So they are gamma delta positive and overlap with the other ones. LYP, aggressive, but they are gamma delta positive. The other ones are not. This is superficial variant. Look like mycosis fungoides, behave worse than mycosis fungoides, and better than the classic variant. And they are gamma delta positive by immunostain. We talked about pannucleus like T-cell lymphoma. This is our kid, the NKT cell lymphoma. So the important thing is EBV positive. And I will stop here. This is when do we check for EBV? Presence of angiocentricity or angiodestruction, mucocutaneous ulcer, cytotoxic immunophenotype, prominent 56 expression, B cells express CD30, presence of both skin and lung, lymphomatic granulomatosis, young patient with facial edema, hydrovacciniform-like. This is usually children, elderly patients, immunodeficiency. So we check for ABV in these situations. So with that, I conclude.